Doctor, you're live. Thank you.
Thank you so much. Good afternoon, everyone. Thank you to SADA and the SAAPD for the opportunity to address the public on a topic that I personally find very interesting and is something I see quite commonly nowadays in practice, and that is grinding and snoring in children. This webinar is the last of the series of a collaboration with SADA and the SAAPD, so I'm quite excited to be presenting this for you all today. I'm Dr. Farah Seedat. I am a pediatric-focused dentist in private practice in Cape Town. This is my 8th year of practice. I'm currently completing a diploma in pediatrics, and I'm also on the committee for the SAAPD. And this series is all about educating the public. And like I said, this is the last one in this series. So to get started, we'll be discussing tooth grinding, which is also known as bruxism. Something to note is that not all grinding is abnormal. Grinding is actually a natural way for our bodies to release stored stress and tension. So when should we worry about it? When grinding occurs regularly and is accompanied by certain coexisting factors, then we should investigate further. There actually is no known exact cause of tooth grinding, but there are commonly found reasons why kids may grind their teeth. Signs that may alert us that it's more serious include worn down teeth, waking up with headaches or jaw pain, or experiencing restless sleep. So of all the causes of grinding, the two most common causes are stress, anxiety, and the emotional state of the patient, as well as airway or breathing problems. So first up, we're going to discuss stress and anxiety. So some children experience a physical manifestation of anxiety and stress, and tooth grinding happens to be one of them. It's commonly found when children experience feelings of frustration, anxiety, and fear, for example, pressure due to high demands in terms of school and social life. Basically, general anxiety and social anxiety can contribute towards grinding. So other factors that we may ask about to assess if this may be the underlying cause of your child grinding would be if there's bedwetting, a sore or running tummy more often than usual, nausea, loss of appetite, stuttering, or even hyperactive behavior, as these may indicate that the child is experiencing an unusual mental load. Some circumstances that may lead to this include, for example, parents going through a rough patch or a divorce, there's a new sibling on the way or a new sibling which has arrived, the child may have started a new school, perhaps relocation to a new town or a country, the child is being bullied at school, being teased, and so forth. So if your child is experiencing any of these, typically we would suggest seeking some sort of psychological help, example, seeing a psychologist or a school counselor, or even family therapy, in order to receive help on how to navigate through these trying times effectively, where it doesn't cause such a burden on the child, and they learn to better manage all these big feelings. And the next most common problem with grinding is airway problems. So when a child has a narrow or smaller airway, grinding can be a natural reflex of pushing the jaw forward to open the airway as the body is trying to get more oxygen in, especially at night when we're laying down and our posture changes. So one of the main things is mouth breathing. So children who struggle to breathe easily through their nose will, of course, mouth breathe, and these patients tend to grind their teeth. Example, kids with a constantly blocked nose, constant allergies or hay fever, enlarged tonsils or adenoids, a tongue tie, or a deviated septum are the most common reasons for children to mouth breathe. So what we as dentists would typically look for would be enlarged tonsils, a tongue tie, of which both could cause a patient's airway to become smaller than normal, how visible their throat is when their mouth is open wide, or kids whose mouths stay open when they breathe. And there is a typical image of a mouth breather, which I'll show you a little bit further on. So if we do see any of these, usually we would refer you to an ENT. to have that assessed. So just to touch on mouth breathing a little bit, this is something I'm passionate about diagnosing and treating, as it can lead to a number of unwanted complications, including facial deformities, crooked teeth, gum disease, a dry mouth, a high risk of cavities, poor development and performance at school, a constant feeling of tiredness, hyperactivity, amongst others, which is simply all caused by a lower than normal amount of oxygen in the body, which is a key element, of course, in children's growth and function. There are so many consequences of mouth breathing that I've come to know about, and this is the reason why I'm so passionate about diagnosing and treating it. For a child to basically develop and grow in the best way possible, we want them to be able to easily breathe through the nose. We don't want it to be a struggle or require an effort. And if it does, then of course parents should seek the opinion of an ENT surgeon, which is an ear, nose, and throat surgeon. So this image just shows you how your face changes when you breathe through your mouth versus your nose. So as we can see on the red side, some common features that people may even notice in public are tired eyes, a crooked nose, the mouth remains open when they are at rest or just walking around, the chin is quite far back, and the head is basically postured forward. And these are all consequences of mouth breathing. An easy sign that a child may have less oxygen than normal is when they have dark circles under the eyes, which is basically called venous pooling, and the setback jaw, which we commonly know as an overbite. So other possible causes of grinding in children could be sleep disturbances, number one, such as sound or light stimulus. For example, the lights are still on or the TV may still be on, and a decreased sleep time. Specifically in children, this would mean less than 8 hours of sleep. And all of these factors were found to have a strong association with grinding. Other factors when it comes to sleep include how long it takes for the child to fall asleep, how many hours of sleep they actually get in, and how often are they being disturbed in their sleep. For example, is there a younger sibling or baby down the corridor that's crying all the time? Or maybe an older sibling in university who's busy in the kitchen studying late at night. And if they sleep, talk, or walk, or have night terrors, these children also tend to experience grinding more commonly. The second reason could be special needs children. There are certain instances where grinding is pretty common among special needs children, and these are autistic children, children who have Down syndrome, ADHD, cerebral palsy, and intellectually disabled patients. So not uncommon for grinding to be experienced in these patients. Number three would be certain medications. Specifically for children, those who are on antidepressants or anti-anxiety medication, as well as ADHD medication. Those kids actually tend to exhibit more grinding than children who aren't on these medications. Number four would be nicotine and alcohol. I would say hopefully only applies to maybe older children and not the much younger ones, but exposure to these two, whether secondary smoke or the child actually smoking themselves, or alcohol, kids who use these can also grind a bit more than normal. And then other habits such as nail or lip biting, finger sucking, and long-term dummy usage has also been shown to contribute to developing a habit of grinding. Therefore, it's recommended to stop these habits as early as possible to lower the chances of the child developing a tooth grinding habit. And the last one is screen time. So children who are exposed to more screen time seem to grind more commonly, and this would include TVs, phones, computers, as well as tablet screens. So how do we basically treat tooth grinding? Basically, it depends on the cause. If there's an airway issue, for example, enlarged tonsils or adenoids, we refer you to an ENT to have those removed. A patient can do therapy to reduce stress and promote a healthier lifestyle, as discussed earlier on. Physiotherapy and massage, relaxation therapy, for example, yoga, to help them learn to regulate their nervous system, anti-anxiety medication, and then something called sleep hygiene, which is basically doing certain rituals at bedtime to hopefully contribute to a better quality of sleep. For example, that could be dim lights, using lavender scented pillow mist perhaps, and just creating a very nice relaxing environment, a warm bath even. And then of course, limiting screen time towards the evening. Also an important part of sleep hygiene is to try and stop all screen exposure from at least 2 or 3 hours before bedtime. So by the time they get to bed, they aren't stimulated with all the blue light and that sort of thing. And then next up, we have snoring. So snoring is a type of breathing disorder which is found during sleep. And when should we worry about it? Well, snoring can indicate that a child is putting in more effort to be able to breathe whilst sleeping. Snoring on its own is not a major cause for concern, but when there are certain other factors present, then it does warrant a further investigation and usually referral to an ENT surgeon. So basically, when snoring occurs more than 3 times a week and your child is struggling to breathe normally whilst asleep, then you may be a little bit concerned. And how you'd know if they're struggling to breathe when they sleep is you would hear like almost gasping or choking sounds, or just strange movements or sounds from the child. This diagram represents the level of seriousness when it comes to snoring. So at the bottom, we basically have primary snoring. That is when you would just hear snoring sounds, but there's no issue with breathing. But the most important thing here is at the top of the pyramid is the most serious consequence or condition, which is called obstructive sleep apnea. And this involves several episodes where the child's breathing either partially or completely stops while asleep. And this can lead to several negative health consequences, such as daytime drowsiness, difficulty in school with concentration, poor performance at school, altered moods, even heart disease, amongst many, many others. So OSA is the condition, or obstructive sleep apnea is the condition we want to be able to detect as early as possible for the child to get treatment ASAP with an ENT surgeon. There are 3 main risk factors for snoring in children. The first one being enlarged tonsils and adenoids. The second being obesity or being overweight. And the last one is hay fever or chronic allergic rhinitis. There are other factors which include exposure to secondary smoke, especially when the mom smokes. So children whose parents actually smoke cigarettes or nicotine-containing devices nowadays are actually more prone to snore than those children who are not exposed to secondary smoke. And lastly, children who have overbites with smaller lower jaws also commonly experience snoring because of the smaller airway, as a smaller jaw means that the soft tissue almost sinks towards the back of the throat, making that airway actually smaller. Just to show everyone what the adenoids and tonsils are, this image just shows you basically where they are, and we as dentists are only usually able to see the tonsils, but the adenoids are usually only visible with an X-ray, as it's much higher up in the throat behind the nose, and that's usually why we'll refer you to an ENT to have the adenoids assessed. So signs that your child may need an ENT assessment when you do notice snoring would include mouth breathing, snorting or gasping during sleep, restless or broken sleep, increased effort in breathing, excessive sweating, bedwetting, unusual sleeping positions, for example, putting the neck out way more than normal, unrefreshed sleep, morning headaches, daytime sleepiness, hyperactive behavior, attention deficit, behavioral problems, and poor academic performance. Something I've found very interesting is that one study overseas found that more than half the children who are diagnosed with ADHD actually have undiagnosed sleep issues. I always tell my patients to seek an ENT opinion when their child is diagnosed with ADHD, as I personally believe in treating the cause of a problem and not just the symptom. So if the ENT says there's no airway issue, then you know for sure that the child may indeed have true ADHD. The treatment for snoring, it basically, again, depends on the severity and the cause. tonsil and or adenoid removal if they're enlarged with the ENT surgeon, the use of a steroid nose spray, which again the ENT will prescribe to you to see if there's a good enough improvement, and weight loss in cases of obesity. It is important to treat grinding when any of the previously mentioned causes are present, as it can prevent a number of issues that would normally develop with grinding later on in life. And if none of these causes of grinding or snoring are applicable to you or your child, then we simply monitor the habit as they get older. Something else I would like to add is a new treatment option, which may be helpful in certain instances, which is a form of therapy called myofunctional therapy, which is basically a form of physiotherapy to train the muscles of your mouth and jaw to move in the most normal or natural way. This is very helpful for those kiddies who have airway problems and are being treated for mouth breathing. And basically, there are just 4 main goals of myofunctional therapy. The first one being breathing easily through the nose, which, as I've said, is the goal for every single child. The lips remaining closed when a patient is resting the mouth. So, for example, in mouth breathers, like I said, you see the open mouth posture where they would be at rest, but their mouth would basically be open. One of the goals of this therapy is to train them to keep the lips closed. Number 3 would be the tongue resting on the palate when the mouth is closed. And number 4, the correct way of swallowing. So just to touch on the tongue resting in the palate, basically when your mouth is closed and you're at rest, especially while asleep, you actually want the tongue to be in a position right up against the palate, forming almost a suction, as this actually forms the scaffolding for your upper jaw to grow. And when that scaffolding is not there, the upper jaw basically, from being nice and wide and spaced out, actually collapses and becomes quite narrow, which number 1 reduces the space for the teeth and therefore contributes to crooked teeth. And secondly, when that upper jaw basically collapses, the airway, which is right above it, instead of having a nice open airway, actually becomes very narrow, which can make the mouth breathing even worse, because say, for example, if you have allergies and your nasal airway is so small and it becomes swollen, you basically force them to breathe through your mouth. So myofunctional therapy is something I actually commonly refer my patients for when I see that they're actually not breathing properly or swallowing properly, or their tongue isn't where it's meant to be. And also when patients have prolonged habits like finger sucking and dummy sucking, it does actually alter the position of their teeth, which then causes the tongue to be in places it isn't meant to be. So that's another reason why I refer my patients for this kind of therapy. So basically, in conclusion, besides nutrition and physical activity, sleep is a very important component that contributes to the healthy growth and development of a child. If there are any signs of a sleep quality compromise that may be detectable by grinding or snoring, then we as dentists are in a unique position to identify these issues to hopefully allow our children to get the help that they may need. And that's it. Thank you for the opportunity to speak to you guys. I'll just check if there's any questions. And we have no questions. Thank you so much to SADA and the SAAPD, and I hope that we can do more of these in the future. Bye.